Are you able to see the slide?
Sir.
Okay, so it Remimazolam bacillate is the salt, and it is called bifavo injection in commercial name, and it is a novel ultra short acting benzodiazepam. Remimazolam is a novel ultra short, much more faster acting than your midazolam, and it is also designed as a soft drug development to achieve better sedative profile than the current drugs. The ester linkage in the remimazolam permits rapid hydrolysis to inactive metabolites by non-specific tissue esterases, and that induces a unique and favorable pharmacological profile with a rapid onset and offset. So the onset is also faster, and the effect also wears off much faster with a predictable duration of action. The pharmacokinetics and dynamics are relatively achieved in a high steady state volume distribution, short elimination half-life, short contact sensitivity half-life, and the faster onset and recovery. So this indicates rapid elimination, minimal tissue accumulation, and a good control with no postoperative hangover effects. And remimazolam has a much more safety profile with low liability for cardiorespiratory depression, and the injection pain is also much less compared to the other benzodiazepines which are used. And remimazolam is well tolerated for procedural sedation and induction and maintenance of general anesthesia also. The mode of action, it enhances the gamma A receptors like all other drugs, causing membrane hyperpolarization, which means they open up the chloride channel and cause a chloride influx, producing extreme intracellular negativity. So the word hyperpolarization means the intracellular ionic level becomes more negative compared to the normal state. So the cell becomes less excitable. So it is designed incorporated as a carbolic acid ester moiety in the benzodiazepine core, and the structural modifications are similar to remifentanil. That is why it is called remimazolam. Part of the midazolam, they have taken that mazolam, and the remi stands for the remifentanil, which is rapidly hydrolyzed by the tissue esterases. And flumazenil can be used to reverse the sedation effect of remimazolam like other benzodiazepines. And the rapid onset organ independent metabolism, that is by the tissue esterases, short duration, predictable recovery, and availability of reversal agent, all of them give a safety profile, superior safety profile of thermodynamic stability. And so this is the structure comparison between the midazolam and remimazolam, and the carboxyl esterases which make the remimazolam break down them into inactive component, and this is the structure of remifentanil. You can see the this is the group, methyl group, which is changed here. So this is the comparison of propofol, remimazolam, and midazolam coming from the strength to weakness side. It is controlled effective fast onset for both propofol and remimazolam. Low liability for respiratory and cardiovascular depression. Availability for a reversal agent. You don't have a reversal agent for propofol, but you have for these two drugs. And minimal pain on injection because they are more water-soluble compounds. And it is propofol is a ready-to-use formulation, and this is also, whereas the remimazolam is a lyophilized powder. So did you mention that point?
No, sir.
Tina?
No, sir. No, sir.
You are so fast, I could not follow many of the points. Okay. So lyophilized product requiring reconstitution. So remimazolam is in a powder form, and possibility of the drug interaction with the other CESA1 compounds, liability to drug interaction with cytochrome enzymes, and the disadvantage with propofol is pain on injection, no reversal agent availability. So this is a comparative chart between these three commonly used drugs. And it is produced as a lyophilized powder for reconstitution. The intravenous, that is the way it is used in sedation in intensive care also, and controlled infusion techniques employing models of plasma drug concentration also can be done with this drug. And the drug is available or being developed as an intranasal or inhalational route also. So from the intravenous route, they are now developing new formulations which can be used by intranasal and inhalation route, especially for pediatric patients or patients with epilepsy and or who are severe agitation, where securing an IV line and giving the drug may be difficult. And the availability of new agent potentially used in combination with reversal agent flumazenil makes a much better anesthesia and sedative technique for in the current era. The dosage and administration to induce and maintain procedural sedation, Remimazolam should be titrated and individualized to achieve the desired clinical response. It is used at doses of 5 milligram over 1 minute for any induction of anesthesia, and supplemental IV doses 2.5 milligram over 15 seconds with 2 minutes between doses can be given if required. And the recommended dosage should be reduced with the ASA classification of the patient. So an induction dose of 2.5 to 5, top-up dose 1.5 to 2.5 on the basis of patient's condition. And to reverse the hypnotic effect, you can give 0.2 milligram flumazenil as an initial dose. It should be injected slowly over 15-second period to avoid possible adverse effects like hypertension, tachycardia, and anxiety. And if the desired level of consciousness is not achieved within 60 seconds of initial dose, that is with flumazenil, then you can give another 0.2 milligram. After a 60-second interval, maximum dose of 1 milligram. That is 5 times you can repeat that. If resedation occurs, repeated doses may be administered at 20-minute intervals for repeated treatment. But if you follow the correct dosage of Remimazolam, because it is faster eliminated by the tissue excitators like your other drugs, it will not have the cumulative effect as people are afraid of. And flumazenil merely based on competitive antagonism. So it has a short life of 40 to 80 minutes. And this is, I have added these points which are not required to be written in your answer, because sometimes flumazenil may be asked as a short note question. So I thought I will give a few points about flumazenil so that you can remember them for that answer if you are asked about it. So the concentration is decreased, hypnotic effect of Remimazolam could re-emerge because flumazenil is a very short-acting drug, as I showed in the earlier slide. And administration of flumazenil should be monitored for resedation, just like the requiralization is a word we used in the earlier days. Resedation can happen after flumazenil also. It doesn't completely reverse like naloxone. And respiratory depression and other recurrent hypnotic effects may be coming back. Adverse reactions associated with Remimazolam are blood pressure and heart rate changes, nausea and vomiting. Additional adverse effects include headaches, somnolence, and hypoxemia. And transient heart rate increase may result from small increase in the QT interval, corrected QT interval. Remimazolam may have lesser abuse potential. That is, people using as a addiction drug is very much reduced compared to midazolam. So lower abuse potential, and the solubility of Remimazolam decreases at pH more than 4. So ringer lactate should not be used, as the point she mentioned. So this is the reason we require a solvent for the lyophilized powder. So that is why this point is very important. So you can just use normal plain water, not ringer lactate. Remimazolam for both general anesthesia and sedation is not available for pediatric population. So at present it is available only for adult usage. And the soft drugs are pharmacologically active and are biotransformed or degraded in vivo, which are termed predictable non-toxic inactive metabolites. So Remimazolam comes under this group. So this is the commercially available drug in the powder form. This is the syringe after reconstitution, labeled with 2.5 milligram per ml. And coming to Fospropofol, it is a phosphate group is added to the propofol. As you all know, propofol is diisopropyl phenol. So if you add a phosphate group to that, it becomes Fospropofol. So the PHOS phos is written as FOS. So remember, a phosphate group added to propofol is the Fospropofol, which results in the formation of a water-soluble compound. So it does not contain lipids, egg products. So the eliminating the allergic bacterial infection or hyperlipidemia problem with the propofol that we are using nowadays commonly. And you can get two products by adding this phosphate group synthesized and named as propofol phosphate and propofol Fospropofol. The substitution of hydroxyl group charged by phosphate is the causes electronegativity, which allows the compound to become dissolved in water, and it does not cross lipid membrane. Sodium salt of phosphorofol are commonly used. So the mechanism of action gets converted to propofol by endothelial alkaline phosphatases enzymes, and it is again agonist at GABA A receptor. It binds to specific site on subunits of receptor complex. Activation results in, again, just like Remimazolam, hyperpolarization with the activation of the chloride content. And also another action is it inhibits the excitatory NMDA glutamate receptors. So there is a double action, one on the GABA and another on the inhibition of excitatory NMDA glutamate receptors, which decreases calcium entry, resulting in the postsynaptic inhibition. So you can see this is the phosphate group, which is a POOO. So this has been added here, propofol phosphate and Fospropofol. So this is the, you can see this structure in propofol, there is no phosphate group. So add a methyl and phosphate group, then it becomes these two components, propofol phosphate and Fospropofol. Pharmacokinetics, it has to be administered intravenously, and as she said, 1.86 milligrams is equal to equivalent to 1 milligram of propofol, and the time-dependent enzymatic conversion releases the active drug by leaving the endothelial alkaline phosphatases. The enzymatic activity of the alkaline phosphate is to remove the added phosphate to bring back the original compound propofol, which is the most active substance. So Fospropofol is only a prodrug, as I said earlier, and the onset of sedation occurs after 4 to 8 minutes, and the dosage is 6 to 18 milligram per kg intravenous bolus to achieve a plasma level, which occurs after 12 minutes. Distribution, the volume of distribution is 0.33 to 0.069 liters per kg after 6.5 milligram. So normally propofol is only 1 to 2 milligram per kg, as you all know, but Fospropofol dose is almost 3 times the original propofol. So 6.5 milligram per kg dose means terminal half-life is about 52 minutes. And it is 98% protein bound and not found to cross placenta or secreted in the breast milk. And metabolism and elimination, alkaline phosphatase present in the endothelium and liver are responsible for the enzymatic conversion. And once it becomes propofol, it is routinely metabolized like the regular propofol that we are using by glucuronidization in the liver, and also extra hepatic sources. That is the advantage why we use propofol in liver transplant also, because it is not only metabolized in the liver but also in the extra hepatic sites where it is glucuronized and made inactive. And formaldehyde also is produced along with that That is the only difference in Fospropofol. Whereas in normal propofol, you don't get that much of formaldehyde formation. And this is the route how it is done. The phosphate group is removed by the hydrolyzed by the alkaline phosphatate. So here you find the Fospropofol with the phosphate group hydrolyzed. Phosphate group is separated. Then it becomes a regular propofol, 2,6-diisopropyl propofol. So it becomes phenol, actually diisopropyl phenol it should be, and then it gets metabolized in the normal way. And it could cause hypocalcemia, muscle spasm, and seizures by the phosphate which is added to that. So the comparison of propofol emulsion and propofol, Fospropofol, it is mainly for infusion. You can use propofol also as a in TIVA and TCI, whereas Fospropofol at present is only mainly for bolus injection, and it is prepared as an emulsion. This is reconstituted. I mean, this is in the aqueous form, and antimicrobial preservative is present in our propofol, which is not there, and liquid water solubility is very low with our propofol, whereas this is highly water soluble. And dose propofol 1 to 2 milligram, Fospropofol 6.5 milligram per kg minimum. Onset much faster. This is slower because it has to be converted to the active form. Duration again 3 to 10 minutes, 5 to 18 minutes. Distribution into the 3-compartment distribution, whereas 2 compartments for the pro-drug and 3 compartments once it is getting converted to propofol. Half-life short duration, sustained duration, terminal half-life is 48 minutes. So Fospropofol has a longer duration because it gets slowly activated by the enzymatic reaction. Elimination, more than 1% excreted in the urine, whereas this is only 0% of the drug excreted unchanged in the urine. Indications, it can be used for induction, maintenance, and short-term procedures, etc. It is mainly as a monitored anesthesia care sedation for bronchoscopy, colonoscopy, and therapeutic procedures like minor surgical procedures. And the solubilizing agents like soybean or L-lecithin, they can produce allergic reaction in propofol, whereas there is no chance of any allergic reaction with propofol. And paresthesia and pruritus absent. Here it is sometimes can be present. And cardiorespiratory depression is more or less. Apnea is 12%, whereas less than 1% because active drug is not injected directly. And bradycardia convulsion can be present with propofol, which is not there. And contraindications is epilepsy in propofol because some unwanted muscular activity can happen, whereas it is not contraindicated in that. So overdosage of Fospropofol also can lead to cardiorespiratory depression and signs of formate toxicity, which is similar to methanol toxicity. And it may produce a high anion gap metabolic acidosis because of the formation of formic acid, ketonemia, and acetonuria, etc. And may produce again if you add other drugs like sedative or hypnotics or opioids with Fospropofol, then the additive effect on the cardiorespiratory system is more compared to propofol emulsion. And there may be a delayed action because of the slow enzymatic conversion. Fospropofol may have a delayed action, whereas propofol is completely eliminated within the given time. And patient's emergence is much more with a clear head in propofol. And of course, uses which are all mentioned in the slide that I showed you here. And this is marketed as a name Lucidra. So this is the presentation, comes in 1000 milligrams in 30 ml vials as a liquid which is available, which can be straight away used. Okay, so these are the points that you have to remember for